Bismillah ar-Rahman ar-Rahim. Good evening. Under musculoskeletal infection, my topic today is titled A Child with Bone Pain, Osteomyelitis and Mimikers by me, Dr. Hanan Abdelaziz, consultant radiologist at Razi Hospital. Hematogenous osteomyelitis is an infection that affects the most vascularized regions of the growing skeleton, so it is a disease of children. Why we have to refresh our knowledge about hematogenous osteomyelitis? Because the disease has been changed over the past 2 decades. It is now more common, more destructive, and more likely to be associated with complications. There is estimated three-fold increase in its incidence over the past 20 years. So by the end of this presentation, you will be able to recognize various imaging characteristics of the clinical stages of osteomyelitis and to consider if any possible differential diagnosis through some of our cases which were done in Razi Hospital. The infection usually starts at the metaphyses of long bone because they are vascular structures containing blood sinusoid and what's called end loop vessels, which allow for sluggish circulation. Other sites in the pelvis where the junction of the bone and cartilage there around the triradiate cartilage, at the ischopubic synchondrosis and around the SI joint. These sites are called metaphyseal equivalent because they have the same structure of metaphyses. Other metaphyseal equivalent locations was called the round bone. Example for it is a talus and any ossific center of any epiphysis. We have three clinical stages: acute osteomyelitis where the symptoms last less than 10 days up to 2 weeks. Subacute stage where the infection lasts more than 2 weeks and mostly due to partially treated patient. Chronic stage where the infection lasts more than 6 weeks. Here in the chronic stage, we don't find these changes as sequestrum, involucrum, cloaca in children. So we don't have any cases for chronic in children. The first 6 cases of our presentation of acute osteomyelitis will show the signs, extension, and possible complication of acute osteomyelitis. This is 11 years old boy. He's complaining of signs of infection around the distal right thigh. His X-ray showing soft tissue swelling around the distal thigh. The bone is intact, which is typical for acute osteomyelitis. You don't expect to have changes in the bone in the X-ray, except after 7 to 10 days from the start of infection. Coronal T1 shows that the focus of infection is in the distal metaphysis of the right femur, easily highlighted against the bright marrow in the proximal shaft in the metaphysis. Stare showing edema in the metaphysis, soft tissue edema, cellulitis. This sagittal PD showing that there is subperiosteal collection lined by the periosteum, which is anchored at the perichondrium at the level of the physis. Sagittal T1 facet contrast is very important sequence. It shows you where is the collection and how much it is. It is intraosseous coming through a cortical defect into the subperiosteal space. Also, you have a soft tissue abscess here in the soft tissue. Here in axial PD, I want to show you that there is also intermuscular edema and subcutaneous edema. So your lesion is ill-defined. It is the whole limb is affected. This X-ray follow-up after surgery showing this complication as a pathological fracture for which he applied a cast and complete healing was achieved. The second case is for a 15-month-old boy, have signs of infection around the right forearm. There is lytic destructive lesion at the distal metaphysis of the right radius. Here we have lesion at the time of presentation, maybe due to the young age of the baby. In this coronal T1, the lesion is ill-defined. Why in this age group? Because there is you have here red marrow, hypointense. Also, you have the cartilaginous carpal bone, hypointense. Unlike the older child, this T1 is not very delineative. In PD coronal, the focus of infection in the metaphysis, and you can see that the infection has crossed the physis to reach the epiphysis. In this age group, you still have crossing vessels between the metaphysis and the epiphysis, and this is how the infection spread. And by reaching the epiphysis, you will have secondary septic arthritis. In this sagittal and axial T1 fat set contrast, you can see that much amount of collection intraosseous, subperiosteal, and within the flexor and extensor group of muscle. He went for surgery. This is a post-operative bone defect, and he got pathological fracture as a late complication. Follow-up in this case is very important because we have here long-term complication as shortening of the distal metaphysis compared to the distal ulna and compared to the other side. Especially if we have this epiphyseal extension, you may have premature closure of the epiphysis. Not in this case. Next case, for 12 years old boy, have signs of infection around the proximal right leg. Here the X-ray is typically normal for the bone. We also have no soft tissue swelling. Coronal T1 showing that the focus of infection is in the right proximal metaphysis of the tibia. High signal in stare with cellulitis, soft tissue edema, and reactive joint effusion. Here in sagittal, you can see the subperiosteal collection. In the axial, soft tissue edema, subcutaneous edema, and this collection. This boy underwent surgery, get improved, and after a while, he's deteriorated, increased C-reactive protein and ESR, and the culture from the wound showing MRSA. They ask for follow-up MRI. This sagittal T1 fat set contrast showing still collection at the site of surgery and the surrounding structure. But I want to show you this. The infection has spread to the epiphysis. In this age group, you don't have crossing vessels, but with this resistive organism, the infection may spread to the epiphysis. After many surgery and antibiotics, he got this complication, pathological fracture. Next case, for 8 years old boy has signs of infection around the left hip, no changes in the X-ray. Coronal T1 pelvis showing that the focus of infection is in the right, in the left proximal metaphysis of the femur. Hypointense in T1, high in stare. What's unique about the proximal femoral metaphysis is this, as it is an intra-articular structure, so you don't have to have epiphyseal involvement to have secondary septic arthritis. The metaphysis is intra-articular, so it is complicated by septic arthritis. Surgery was done and no long-term growth disturbance or physeal bridges. Next case, for 2.5-year-old boy have signs of infection around the ankle. Here we have hypointensity within the talus, high signal in this sagittal PD. The talus is an intra-articular structure, so you have this reactive joint effusion and synovial thickening. Sagittal T1 fat set contrast showing you where is the collection in the head of talus. You have to point to this, so it will be targeted by the surgeon. Also, you have that enhancing infected synovium. Next case, for the last for acute group, 4 years old girl. By the time of admission of this child, she had elevated liver enzymes, impaired renal function, hypoalbuminemia, ascites, and her blood culture was streptococcus. All signs point to her left hip. Here in coronal stare, you have marrow edema, soft tissue edema, enlarged lymph node, joint effusion, but you have to carefully look where is the primary focus of infection. around the triradiate cartilage here in the pubic part of the pelvis of the acetabulum. This is the focus of infection, and typical for this flat bone of the pelvis to have mild bone affection, contrasting the very big soft tissue involvement, and don't misdiagnose it as cellulitis or septic arthritis. Her axial T2 is showing the joint effusion, soft tissue edema, and here two pockets of infection, more caudal around the pubic part, pointing to the primary focus. In this axial T1 facet contrast, you can see these two pockets of collection and very enhancing infected soft tissue. After surgery and antibiotics, she, alhamdulillah, got complete resolution. Subacute osteomyelitis, where the infection lasts more than 2 weeks, it has an insidious presentation. But on X-ray, plain X-ray, you have this classic appearance of what's called Brod's abscess. Our next 3 cases will show you subacute osteomyelitis. This is a typical Brod's abscess in a 15-year-old boy. It is osteolytic, metaphyseal, resting on the physis and surrounded by sclerosis. By this typical appearance, this boy underwent debridement and got resolved. Next case, for 4-year-old boy, he has this lytic lesion, metaphyseal, resting on the physis with rim of sclerosis and some pre-osteal reaction. T1 showing hypointensity of the lesion, high signal on stare, and in post-contrast coronal and axial facet, you can see this typical appearance of the subacute, which is called the penumbra sign. Central fluid collection surrounded by zone of enhancing granulation tissue before the sclerotic margin. Here we also have enhancing soft tissue, but without that dramatic appearance of subcutaneous and intermuscular edema. This is a penumbra in T1. After surgery, this has that bone defect with complete healing with no growth disturbance. Next case, for 4.5-year-old girl, lytic lesion in the talus surrounded by zone of sclerosis. Here in coronal T1, you can see the central hypointensity, and you can see how the penumbra shown in the non-contrast. Still, we can appreciate this hyperintense rim surrounding the hypointensity. The lesion is high in stare, and it is an intraarticular, so you will expect this synovial thickening and effusion. T1 facet, T1 sagittal and axial contrast showing typical penumbra appearance, central fluid, zone of enhancing granulation tissue, and the rim of sclerosis that well seen in CT. We have here mild joint effusion and enhancing synovium. Now, can it be anything else other than osteomyelitis? Yes, any disease that can cause marrow infiltration, inflammation can be confused with osteomyelitis. Our next 4 cases will show you some of the differential diagnosis. In these cases, you will receive request saying 3-year-old boy having pain and swelling in the right leg, osteomyelitis or tumor. And if you reported osteomyelitis, the patient will go directly for surgery. And if the report came with tumor, he will go for biopsy and dealt with accordingly. The least favorable, if you reported osteomyelitis, however, tumor couldn't be ruled out, this will not help anyone. I will show you some clue. If you will see, you better ask for biopsy. This lesion, this initial X-ray, you have already lesion, unlike osteomyelitis. There is X-ray changes at the time of presentation. The lesion is metadiaphyseal. It is lytic and somehow sclerotic, mildly expansile, with some cortical thickening. With this data, I will take a mental note and go for MRI. hypointense in T1, high in stere, and this in contrast sagittal T1 facet. You can say this is fluid collection come through cortical defect. But with a careful look at this, what look like collection, it is signal void in stere, so it is not fluid. Together with cortical thickening, and in this axial T1, there is no intermuscular edema, no subcutaneous edema. The lesion is well defined. So biopsy was taken. After 2 years, the boy has another lesion in his right iliac bone. I am sure now you know the diagnosis. It is histiocytosis. It is characterized by accumulation of histiocyte. It can be seen in children under the age of 14, can affect any bone. When symptomatic, the patient may complain of pain, swelling, tenderness around the lesion. Systemic manifestation may be there as malaise and occasional fever and leukocytosis. That's why it may be confused with osteomyelitis. Next case for 6.5 years old girl. She has pain after minor trauma in her left knee. The initial X-ray as well as clinical and laboratory were unremarkable, so they kept her for follow-up. Her follow-up X-ray showed this lytic lesion in the proximal metaphysis of the left tibia. It can be bilocation osteomyelitis. However, you don't have soft tissue swelling, and if you carefully look here, you can see circumferential periosteal reaction. This is not the case of osteomyelitis. Again, we'll see what the MRI will tell us. Hypointense in T1, high in PD. In this axial post-contrast, you can see intraosseous fluid collection and cortical defect with surrounding soft tissue edema and enhancement. This can go very well with osteomyelitis. But here in PD and also in this axial, I want you to see what is this. This cortex is permeated or moth-eaten. This is not the usual case with osteomyelitis. In osteomyelitis, I will get an intact cortex through which only necrotic area, a defective area, but the rest of the cortex is intact. So for this case, we take biopsy and it revealed Ewing's sarcoma. Ewing's is the second most malignant bone tumor in children. In the long bone, it can affect the metadiaphysis. They said that radiologists usually misdiagnose osteomyelitis as Ewing's than vice versa. Our next case for 10 years old girl, she has recurrent pain and swelling in the right clavicle. Here we have the medial 2/3 of the right clavicle is expanded by sclerotic lesion. This axial oblique CT showing the expansion, the sclerosis, and the lytic area of the clavicle. In her coronal stir, there is high signal within and surrounding the clavicle. In this axial post-contrast T1 facet, there is no collection. There is enhancement of the lesion and surrounding the lesion. Since there is no collection, so no surgery and also no biopsy, because this is very typical appearance of what's called chronic recurrent multifocal osteomyelitis. This is a self-limiting process characterized by recurrent inflammatory lesion affect only the children. It is a diagnosis of exclusion based on no organism, no abscess, atypical location, and may often be multifocal. Our last case, a 9-year-old girl has pain in her right leg. The bone is okay, no soft tissue swelling. This coronal T1 showing that the lesion is mid-diaphyseal, unlike acute osteomyelitis. Instead, there is marrow edema surrounded by soft tissue edema. In this post-contrast, there is some enhancement in the marrow and surrounding structure. In this axial post-contrast, no collection. We have this circumferential periosteal reaction and enhancing inflammation around the bone. I want you to appreciate this cortex. This is how the cortex shown in the axial view. No collection, no surgery, follow-up showing this sclerosis at the site of the lesion, later on complete remodeling and effusion and resolution. I am sure you know now this is an infarction. It was the first time this girl known to have sickle cell anemia and infarction. Infarction is an intramedullary meta or diphyseal. Early there is edema, periostitis, then calcification. Then we came to the conclusion that osteomyelitis can be difficult to detect clinically as symptoms, examination, laboratory can be variable. Knowledge of the basic pathophysiology is prerequisite to understand the imaging appearance of osteomyelitis. The presentation of the disease may vary depending on the clinical stage, acute, subacute, chronic, the pathogenesis, and the age of the patient. Depending on the clinical context, the following differential may be considered: histiocytosis, Ewing's, infarction, CRMO, or stress fracture. Thank you for listening, and thanks for my fellow speakers and the board committee, Dr. Masha'al, Dr. Reem, and Dr. Wael. And thank you my colleagues Razi and Dr. Khalda Dashti for their continuous support. Thank you.